around the jugular foramen, above that, because it is giving a blush there behind the tympanic membrane.
Yes.
So most likely it's a jugular foramen, glomus jugulae as such.
Yes.
And the extension of the tumor, if you could see on the MR, it looks like C1, C2 is going up there because it is going up to the vertical portion. Then when the first GU is there, it is going up there, up to there.
Yes.
So I think I'll directly take it as a glomus jugulae. Then I'll try to plan my surgery accordingly. And look into the age and all those parameters for the surgery.
We'll come to planning. So, never biopsy an oral polyp. Okay, especially if it's a pulsatile mass, don't biopsy any polyp. Okay, if it's a malignancy, the features are different. It's not really a polyp. So, unless it's one of those cases, do not try to biopsy a polyp. You could be biopsying an aberrant carotid or a carotid aneurysm. And that's the end of the patient. If you're doing that in an ambulatory, if you're doing it in an OPD, that would be a disastrous thing to do. So, diagnosis and classification. Yes, Pawan has touched upon the classification of the class. Could I have any other opinion? Do you think it's class C2? Amit?
The posterior fossa seems to be exposed with the tumor.
The posterior fossa. Okay, that's a good observation. Yes, I was coming to that. Good. So you think that it could be a D? It could have a D class.
It could be DE1.
D extradural. You want to have a look again at the MRI?
It's not going inside, but at least that for
it's touching it. There's a down. Let's see the MRI again. So I have that was one of my questions. So to classify the tumor means that you have to study the pre-operative pictures very well. So unless you do that, you're not going to classify. And that's one of the. You see here that the tumor is very much in contact with the posterior with the cerebellum. And then, I'm sorry, let's go here. Also here. You see here? So that tumor is touching the brainstem of the cerebellum. And in this, also you see, there is something there. And now we have to determine whether it's intradural or extradural. So, yes, so any other opinion on this? Anything else? All the panelists in concurrence about the fact that this is Dr. Jonathan Paul, could you please tell me if there's any other classification that you would be interested in, or would you go with the fish classification? Because that's what we're talking about, C and D. Okay. Again, I come back to the terminology. I think we should stop calling this glomus. We should either call them tympanomastroparangiomatosis or tympanojugular parangiomas. These are not glomus tumors, and that's something that should be avoided. So the fish classification, we went through this, so I won't go through this again. So there's C1, C2, C3, C4, and let's skip this. So this is a case of a C2. Yeah. Yes, that's what we agreed upon. D intradural and 1. Okay, I studied the scans quite well. This is just a picture. We don't have the time to really show it on a wide screen. So it is an intradural tumor going across, but less than 2 centimeters, so it's intradural 1. So what would be the surgical approach?
Before we go for surgical approach, I think one more testing which we follow at our institute, the cross flow testing.
Cross flow, okay. So that is in this case, would you do it if it's a C2?
The cross flow is a must.
Okay, so you do it in all cases?
In all cases, we do cross flow.
Okay.
Simple balloon occlusion may not give you that much idea.
Okay.
Cross flow will definitely, in case you need to sacrifice it or you injure it, at least contralateral circulation, whether it's filling it or not.
Okay. So, yes, a 4-vessel angiography, including the carotids and the vertebral artery, is an investigation of choice in tympanojugular parangiomas. And in this case, of course, we do it in all cases, but in a center which really doesn't have facility. In my case, for a C2, I would probably not be so keen.
Probably you wouldn't go for that if
Yeah.
you don't have that facility available, or it is costly. Like
Yeah.
for the Indian subcontinent where poor patients are there, I think you can go ahead.
Yes, so it is here, it is just touching the carotid.
Yes,
and
you can see a plane there.
Yes.
I could see it is just touching the carotid
Yes.
vertical portion, and the first genome it was touching, that's it.
Yes.
It is not going beyond that.
Yes.
So I think you don't require that in this particular case.
Yeah.
And regarding D1, it is because they are touching the posterior fossa dura
Yes.
that is easily amenable to surgery. You can take out a piece of the dura along.
We will come to that. We will come to how to deal with the intradural component. But so okay, let's complete the investigation. So we come back to the point that Professor just said. In all cases, it's more important to do a venogram to see if the opposite glucosigmoid complex is patent, because if that's very narrow, then you could be dealing with the dominant glucosigmoid complex, and closing this could be a problem. So you may have to probably abandon surgery in this case. Okay, so surgical approach. Any other opinion from the panel, Dr. Saleh?
I'm a plastic surgeon, so I put these things back
Okay.
together. So I'm happy for you to make the biggest hole in you like.
Okay, Dr. Pollock?
Well, I'm afraid to say, you were so subspecial.
Yes.
This would be one tonight I would definitely
Okay, so, of course, yes. So, the rest of my colleagues would agree with me that we could probably be going for infratemporal fossa type A. Is there any discussion of this? Type A? Okay. So, infratemporal fossa type A is an approach of choice. Now, what do we do with the intratemporal component is something I will discuss again. But in the infratemporal fossa type A, would you do a partial rerouting or a complete rerouting as I showed you in the picture? In this case.
This case is a difficult one because the tumor is going posteriorly also. It is going pre-sigmoid, it is going the Citteris angle, it is going towards the posterior fossa dura. So to reroute the facial nerve in such a lesion, you do have some difficulty down there. Either you can reroute it far posteriorly, but that's not possible because it is going towards. So I think partial rerouting, or maybe it is just making it naked out of the bone cover, and you can move it upside down, or maybe anterior posterior doing a surgical excision.
Yes, Amit?
I think rerouting has to be done as far as I believe, and that's true. We don't need to fix it because we need to go anteriorly also, because it's going up to the genome. And posteriorly also.
Yeah. Agree? Rerouting complete or partial?
Complete.
Okay. Right. Dr. Pasricha? Okay, so I'm sorry. So that leaves us, yes. So you have any opinion?
In my opinion, also, it's all depend on what you find during intra. Whether the tumor is involving or you can handle it without this manual or not. It's all depend on intraoperative. It is in intraoperative list rather than pre-operative.
Okay, so I would like to say that in this case, since the tumor is touching the carotid and C2 means going up to the genome, which is genome between the vertical and the horizontal segment, I would like to reroute this completely. So I'll begin with a wide exposure by a total rerouting of the facial nerve. I will not attempt a small exposure. So I would do a total rerouting of the facial nerve. Now, what do you do with the intradural extension? So that's the big point in this particular case. The carotid is not really a big problem if you're a skilled surgeon. In this case, the carotid is not a problem. There are other cases where carotid is a serious problem with the paraganglioma. But in this case, you see that the tumor is going intradural despite being a small C2. We have seen some cases where it's a C1 which is going intradural. Very rare, but we often see. So, Dr. Sharma, what would you do intraoperative? Okay, you're doing an infratemporal fossa type A, partial, total, whatever, rerouted, and you know that you could end up in trouble because this is a tumor going inside, and then you try to remove, you know that it's infiltrating the dura and going inside. So, on the table, what would you do? Or have you a plan beforehand?
not much of a tumor in the interior.
Yes.
So if you do the rerouting of the cell path, then it is easier to you to handle the interior compartment. You just open the dura, you can take out the tumor out of the dura. And as far as the one thing, you only the closure of the dura. So you can pack it with the fat, or you can also use a graft along with the biological.
Yes, with fibrin glue. You use glue with.
When the tumor is intradurally engulfing the lower cranial nerves or seventh complex and going sometimes to the ancestral also. Then it would be difficult to handle.
Yes, but in this case, you would go primarily in the same sitting, you would follow the tumor intradural.
Same.
With a small CSF, with a small dural defect, you would close the CSF leak by putting fat and with a little bit of fibrin glue. This would be this. Any difference in opinion?
I think your concept of a second surgery after 6 months can't be applied over here. It's a small portion just touching the dura or maybe infiltrating inside. So you can take a wide margin of the dura along, and before that you have to do a lumbar drain so that you don't have that stage of gusher intraoperatively. You have to deal with the small vessels there, you have to dissect it properly. The proper time should be given. Yes, so you can take it out and fix it up with the fascia maybe or something else. Then you can pack the cavity with the fat.
With fat.
With fat.
Okay. Any other opinion?
That's fine.
Anything to add to this? Nothing. So this is exactly what we did. See, we found this, the labels are self-explanatory, so we found this small piece going inside here. I'm sorry that the label is covering it. And then we went ahead with the surgery, and then we had this defect, which is not so big. It looks big because it's under the microscope. And then we went ahead and plugged fat, put fibrin glue, exactly what the panelist told me. And in this case, we didn't apply the concept which we preach, which is to do a second stage surgery because it was a small defect. So far so good. So all of us are in concurrence. So again, I go through the tenets of paraganglioma, extent and type, associated lesions, involvement of nasal vessels, collateral circulation, intracranial extensions. This is a rather difficult case. So it's quite obvious that the panelists will agree with me that it's a C3, D1, 2 tympanicular paraganglioma. But in this case, there was also vagal paraganglioma, which is something we will not really discuss because it has to be dissected. Because we're going down to the neck, dissect the vagus as well in the same sitting. But what's more important is the carotid is here. So what would you do in this case? And this is the picture. This is lower down in the neck. This is the carotid, and there is kinking here. So what would you do? Let me rephrase this question.
Yeah.
From a management point of view, would you do a surgery, wait and scan, or RT? Let's begin from there. Let's get into the surgical part. I know all of us surgeons would like to.
I clearly observed your presentation before this thing.
Yeah.
And there's so much kinking. You can't put in a stand down there.
No.
So you have to kind of cross the machine.
Yes.
You will have to reset the carotid and you have to be prepared for it.
But stepping back, by one step, are you convinced about surgery in this case? 55-year-old man with a CT D1, 55-year-old man with this tumor.
If he has not got any cranial palsy,
he has all cranial palsy.
He has got that.
Yes, all cranial.
And that means he is also having lower neural problems like maturation, situation problems and all.
I don't have the data, but
and then we have to intervene in this patient.
For surgery. So anybody else with a different opinion?
Surgery will have to be done. At the max, the catch may be whether if you are not able to resect it completely, then at least you debulk it to the significant size. Maybe it may be a case for residual management.
Residual. What would you do with the residual? Then irradiate?
Radiation or maybe stereotactic.
Stereotactic. So you are looking at surgery with partial resection followed by radiotherapy for the. So you're convinced about this, or are you going to follow and see if you can remove it and then take a decision? Or have you made up your mind? Is this going to be a pre-planned partial resection?
No, not pre-planned.
You're going to resect as you go along.
You have to plan for complete.
Okay. No, I was just thinking about the ideology. I was just thinking about a frame of mind, how you would approach this. Sharma, Hitesh?
We can do other stage surgery.
Stage. Two stages.
Another option is exercise and wait and watch for that residual part. And third option is if it is extending, we follow, we can do it.
Okay. Okay. Any other opinion?
One option,
yes.
Another thing is that suppose if there is a no cross section is possible, pre-operatively we can plan for the bypass surgery before
Bypass. You prefer bypass.
So you can at the time of the surgery you can even like it. You do pre-operatively surgery for revascularization distal part.
But between the bypass and the permanent balloon occlusion, what do you prefer?
Yeah, of course. This is the
You prefer bypass.
balloon occlusion is must before you decide anything.
Okay.
I think it's a difficult job to bypass to the second up to second geo of carotid. It's a difficult job.
Yes, I agree, because if we are to follow the C3 going all the way up to the horizontal segment, bypassing a carotid within a bone, because you don't want to cross the lateral segments. So bypassing that area would be a little bit of a problem, though not technically impossible. I would still go with permanent balloon occlusion and making sure that this is not a familial case. Because if it's a familial case, then again you have other problems. Because this patient would develop another tumor on the other side, and then you're thinking about the carotid on the other side. So, but if it's not a familial case, so yes.
Just a point to make about him, I think he's the kind of guy who's an ideal candidate for a thorough multidisciplinary discussion. That's the only point to make about him. I think I would probably offer him surgery as well, but he should have an opinion from an experienced radiotherapist. And it's the kind of patient where when we first meet them, we say to them, we've got a little bit of time to work you up for this. You know, you can do your preoperative assessment, we can get you to an experienced radiotherapist, have an NDT discussion about it, so we've got a sort of balance with that. But I think he probably would come to surgery if most units in the UK.
Okay. Anybody else? Okay, so difference of opinion, but both points taken. Now, our indication for weight and scan, why I asked you this question on weight and scan was because our indication is in elderly patients, low cranial pulse in the elderly. I've dealt with this before, so I really don't want to go, because we're running short of time. I want to show you other cases. Normal, I've dealt with this, so let me just skip Now, does RT have a role in this is again something I don't seriously believe in, because despite the advances in radiotherapy, I feel that there is, I've discussed this in the previous presentation, I'm sure you don't want me to go through this again. I'm not saying that there is no role, but there is definitely a need to question the role of radiotherapy. So we have to take it with a pinch of salt at the moment, and we surely need some more research in the that deals with the efficacy of radiotherapy in differential pathologies. Now, what did we do? Okay, I'll skip this. We did a permanent balloon occlusion. We removed the carotid body tumor with Vegas paracardium along with this. You see that the tumor is involved in the carotid. There's a lateral semicircular canal left here. So, middle fossa dura, posterior fossa dura, the carotid is ligated. Left behind this intradural portion. After 6 months, we left behind this labyrinthine block as a landmark. We went inside intradurally and moved this tumor completely. And this is how it looks after surgery. After the second stage, you see only one carotid. We just hope that she doesn't get a paragonal on the side. Now, jugular tubercle eroded, occipital condyle eroded, going far medially. You see that this tumor, this is another case, involving the carotid. You see the highly vascular, involving the carotid for sure, with the intradural component, with the long leg component, managed.
I'm not my fault. I just refer the case to Eisenberg.
Okay. Maybe to Rupa? Yes, okay. Okay. Thank you. And Amit and the others? Everybody refers to this. Okay. Okay, so again I go back to the slides. Big tumor. involving the carotid, going intradurally, everything possible. In this case, is stenting of ICA. Let me answer that question. ICA stenting is very much an option if the carotid is not kinked. And in this case, I would stent the carotid and remove the tumor. And this is where we make a difference. This is where stenting makes a difference. It becomes resectable when you stent. And that's the only difference between this reply of referring to our center and not. Now, if you're able to develop, have a good team with a radiologist who can stent the carotid, I'm sure you can do this too. But the problem is that you're not very, yes, exactly. You need a good amount of training. So, we have our indications. So, we stent. And this can be done all along the parafrontal carotid, vertical, geno, horizontal, right up to the lateral segment. I told you that it becomes an intima. We dealt with this. This is the stent after surgery. We've done 30 cases, no complications, no blowout, no events of follow-up. So what did we do in this case? We did a transtubercular transcondylar extension going all the way up to the occipital condyle. So that big tumor, there is no tumor typical of the paradigm that cannot be operated. What did we do? This picture, if you remember, we drilled out the area of the jugular bulb, jugular tubercle, hypoglossal canal, occipital condyle. All this was removed right up to the hypoglossal canal. That's where we stopped. And then we had this, that was the temporal component or the infratemporal component, which is completely cleared. And we left behind the intradural component. And you see, this is stenting. You see the tumor anterior to the stent. Can you see the stent through the, through the wall of the carotid? This is tumor posterior to the stent. All around the stent, you can see here, the stent is intact. We left the Levantine block, and then we went ahead. I showed this video earlier. We went ahead and dissected the intracranial component, and this is using erythrosigmoid or spots or whatever you want to call it. There's no real sigmoid has been closed, and this is the final bit of tumor that has been removed. The only difference here is between the surgeon who will do it or not is stenting. And this is the final. Okay, so I would just show you one case more, and then we stop. Yes. Okay, so we stop. No? Okay, thank you.